Today, we will be presenting a radical prostatectomy for prostatic acinar adenocarcinoma. We will dive into prostate anatomy and the proper sampling to get an accurate diagnosis and staging. Let's begin.
Good morning, everybody. I want to thank you so much for taking time out of your mornings to join us on these rounds. And we're just really thankful for the community that we've been able to create together. And yeah, just glad that you're here. Okay. All right. So should we go with our first specimen of the day? Okay. Hold on. So what kind of specimen is this? Just the poll questions are indeed anonymous, so feel free to click the answer that you think is the most correct.
And really, the poll questions are just like a launching pad for our discussion.
I'm glad that nobody selected TERP because we saw TERP and this looks nothing like that. The second answer is the transurethral resection bladder tumor. And again, it would be a fragmented specimen. So most of you have selected the correct answer. This is indeed a radical prostatectomy. Going back to a couple of the answers previously, the third answer is a radical prostatectomy. What organ are we missing here to make this specimen a prostatectomy? Bladder. So we're missing the bladder. A prostatectomy would be a complex resection which would include the bladder and the prostate gland together. Here we really just have the prostate gland. By contrast, a simple prostatectomy, can anybody tell me what that is and how that's different from what we have on the bench today? No seminal vesicles? Technically, that's right. So the simple prostatectomy are specimens of prostate nodules and hyperplastic nodules, generally closer to the urethra. They won't have the seminal vesicles and the vas deferens attached to it. What's been resected is just a nodule of hyperplasia, and there's still some prostate gland left behind. By contrast, the radical prostatectomy would include the whole prostate gland with the bilateral seminal vesicles and the vas deferens. We generally don't see too many simple prostatectomies anymore. Okay, so going through the anatomy, the prostate gland is a walnut-shaped organ. You can kind of see this has a walnut shape to it. We split them off into both the left and the right sides, as you can see evidenced by the inking that we've applied to the prostate. And down the middle, you've got the prostatic urethra. All around, you've got the prostate gland. Posteriorly, you have both bilateral seminal vesicles that extend like little wings off the back to the lateral sides of the gland. Then right down the middle, you'll have both vas deferens. They sit in the middle more medially. Normal weight of a prostate gland is about 20 grams. This one is almost 34 grams, so a little bit larger. Anatomically, this is where things always get a little bit confusing. The base of the prostate is actually at the top. This is the base here. It's also called the bladder neck. And then when you come down to the inferior aspect, this is called the apex. And so that's the bottom part of the prostate. It can also be called the apex or the distal urethral end. And again, the urethra then splits the gland onto the right and the left sides. The prostate gland itself is divided into 4 distinct anatomic regions. The first being the central zone, and it's kind of back here in the superior and posterior aspect, and it surrounds the ejaculatory ducts, and it's the smallest zone in the gland that we divide out. The peripheral zone is the largest of the 4 areas, and that encompasses roughly about 75% of the gland. As the name suggests, it's the periphery of the gland, but the majority of it extends actually posteriorly. The third zone is the transitional zone. And this is the area that surrounds the urethra as it enters the prostate gland here at the top. And then this sits kind of in this anterior and superior region of the gland, and it'd be kind of up in this area. Lastly, the last zone is the periurethral zone, the zone that surrounds the urethra as it extends down through the gland itself. As you receive the specimens, it's always very, very important to weigh the organ to be able to do your painting. At Sinai, we elect to use green for the right side, blue for the left side, and we paint that kind of circumferentially all the way around. There's probably differences in practice in terms of where you are, whether you apply 2 colors or 3 colors. This is just what we do. I believe Susan Lester in her text talks about blue and black, but just to say that there is going to be institutional differences in practice rather.
So I'm just curious, how many out there is doing more than just 2 colors?
4. Oh, interesting. And I guess it's like anterior, posterior, and then right, left, I'm assuming?
Sorry, anterior, posterior, left and right.
Left and right.
Okay.
Yeah. Ah, interesting. Painting the seminal vesicles a different color. Okay, painting of the 4 quadrants. So let's go back to our specimen. And to evaluate any of this, you of course have to cut it. So let's do precisely that. Okay, so when we're handling the prostate gland, ultimately what we want to do is cut transverse sections all the way across from the base to the apex. You can see that this isn't this nice kind of round gland and that there is a bit of a flatness to the bladder neck, and the apex comes to a point. You have to be thoughtful in terms of how you cut to get these nice transverse slices. What I usually do here is dissect off the seminal vesicles to get them out of the way.
So we're doing a live cut, everyone.
Just keep them organized, put them back in view, wherever. There we go. So you're left with just a prostate gland now. My first cut is I usually take off the apex. You're going to be cutting in about 3 to 5 millimeter slices. If you need help, you can always, again, just take your probe and just get a sense on how your urethra sits. So then you can square off your cuts to get some nice even cuts. We're going to take that first 3 to 5 millimeters of the apical margin. Okay. And that's the apex. And then I'll do the same thing with the base. But again, I'll just change the angle of my cut so that I can get a nice full face cut across the bladder neck. Let's see what's best
I
here.
find that this is always so challenging just because of the shape of the prostate and how you kind of have to angle your cuts.
So we've got our apical margin over here, and we've got our bladder neck margin here. And so now you can see by doing so, we've squared this off a little bit. I'm just going to turn this up a little bit so I can avoid cutting wedges. I'm going to try to transversely section this into rings as best as I can.
While you're doing this, just making sure that you're keeping track of the orientation, right? Inferior to superior.
It's nice when you look at the cross sections of the urethra to kind of keep your orientation. It looks like a little upside down. And so that helps you kind of keep your superior from inferior. That one's a little thick. Okay, we'll stop there for now. There we go.
So on the top part of your screen are your left and right vas and seminal vesicles. For the prostate slices, starting from the top left-hand corner of your screen, that's the inferior end or the apex, moving across and then down diagonally or moving superiorly into the bladder neck or base margin.
Let's just pick one of these slices and get some descriptors on what we're seeing here.
So what do people think? What do you see?
Maybe something here. It's mildly nodular. It is a little bit spongy. Spongy in terms of a texture would be normal or prostate, and some of that cystic appearance you can see here. Again, kind of normal looking prostate. So it's brown. It's really hard to actually see anything, right? This is the challenge with prostate, is that often it's really difficult to appreciate lesions and tumors grossly. Generally speaking, they'll infiltrate into the surrounding parenchyma, sometimes in a diffuse pattern, sometimes in a nodular pattern, but very often kind of mimicking the surrounding normal prostatic parenchyma. And so the key here is just to look for areas that are a little bit more solid in appearance and being able to palpate and feel, what feels a little bit more firm than not. But again, with formalin fixation, everything feels a little bit firm. So it's difficult to palpate some of these lesions through these prostate slices. By contrast, in the breast, for example, we are always trying to palpate through and feel those textural differences. We don't have that luxury sometimes in the prostate. You're looking for areas that are a little bit more ill-defined, a little bit more firm. You can see perhaps here, like towards the urethra, you can appreciate that it might have this more spongy appearance, small cystic spaces, perhaps alluding to more normal looking parenchyma. As you get towards the back, you lose some of that definition. This might be representative of a tumor, but it's really difficult to say on a gross level and to be able to call that a lesion. Yeah, so anterior, the camera's not picking it up quite as well. On the slice here, it's a little bit more chalky. It's like yellowy and a little bit orange, but I think the camera's not quite grabbing that as well. You can kind of see the contours of it. Texturally, it's more rubbery than it is firm. Okay, and if we just try looking at another slice, similarly, there's not a ton that you can appreciate grossly.
Mm-hmm.
If you could see the lesions, though, most of these tumors, if they are sitting in this peripheral zone towards the back, they generally are white, a little bit more tan. And then if you move into that transitional area where it's more kind of anterior and superior, these tumors typically will look a little bit more orange or yellow. Because this is so difficult to see, a lot of protocols will suggest submitting these specimens through in toto. So in the chat, let us know your site's approach to submission of sections for prostate glands. Is it like an in toto kind of thing? Are there cutoffs? Okay, so the posterior in toto and then alternating anterior, good. If in toto under a certain weight, yeah, so I've seen that a few times at a number of sites. And then some may suggest using clinical history and the biopsy to focus and tailor your sections to where the biopsies were taken and what the previous biopsy showed. So I think generally speaking, everybody looks like they're on the more aggressive end in terms of what they're submitting. Good. And for us, we will submit this through in total, given its size, given the fact that we can't appreciate a gross tumor. Generally speaking, we'll submit these prostates through in their entirety. There's a number of different ways that you can approach the sampling of these specimens. And so one might be to divide each slice with the exception of the margins, and we'll get to that in a second. Divide each of the slices into quadrants and then submit each quadrant section in a different cassette. You would articulate slice 1 or slice 2, slice 3, 4, 5, whatever it is, and calling each individual section as right anterior, right posterior, left anterior, left posterior. Another way of doing it, and some sites prefer this way, is to submit the posterior quadrants first, moving from the apex to the base. You cut each of the slices into their respective quadrants and submit all of the posterior on the right side first, and then all of the posterior on the left side. Some sites will selectively choose and represent the anterior halves on both the right and the left, and then other sites might elect to put the whole thing through, including the anterior halves. For us here, our approach is generally to submit the posterior quadrant first. By doing so, we'll cut each slice into quadrants and then submit that through. When it comes to the apex and the bladder neck margin, we'll submit those as margins proper. So how do you submit your apical and your bladder neck margins at your specific site? Do you do them radially? Do you do them as perpendicular sections or on FAS? Or perhaps your site considers these not margins and we don't submit them.
Do you take a picture and provide that as a map?
Yeah, so that's an option. It's not something we do here routinely, but that's definitely a helpful tool to map out your sections if that's something that the pathologist is keen on having. Good. Okay, so yeah, there's a little bit of differences. Some have opted to do the radial, making these little wedge shapes that go through both the left and right halves. The perpendicular would be these perpendicular sections across the face of each of the margins. The on-fast section doesn't happen too often, if at all. And I'm glad that nobody actually considers these not a margin and so that they are submitted. The radial approach is perhaps an older approach to submitting these margins. With the College of American Pathologists, their recommendation is to do them perpendicular. And so that is our approach here. Generally speaking, we'll work from the apex and then up towards the base. This is our apical margin. You can cut straight down the center where the urethra is, that. Okay. And then again, in 3 or 4 millimeter sections, you're gonna cut that through. I usually start with my right side. That can now go in a block, just like that. Similarly, we'll do the same with the left.
And so you would label this right side apical margin.
Correct. So in my block code, my first block would be right apical margin, right side perpendicular. Okay, there you go. So now I'm going to work my way through the rest of the prostate parenchyma. And again, because our approach here is to take the quadrants and then submit the posterior side first, I'm just going to start off with this first slice. And again, you can just keep yourself organized on your bench and then just start working your way through and taking sections of the right side posterior quadrant.
You have to be super organized here. I am curious, the community out there, anyone do hole mounts for these?
Yeah, it's a great question.
Oh, we got a vote. Hole mounts. Wow. Okay.
That's awesome.
I totally agree. I think that's actually helpful.
I presume then your site probably has a sledge microtome that allows you to cut these hole mounts.
Yeah.
Wow.
Curious, for the hole mount process, was that always since the beginning, or is this just more recent with prostates being sampled or submitted in toto nowadays? Okay, so it's recent. I remember back in the day, submission of prostatectomy specimens were very simple. It wasn't quadrant based. It was literally like representative sampling only if you see something. It's going a similar way to how lumpectomies, or at least for breast pathology or breast growth pathology submission is, in that we're being a lot more meticulous and organized. But yeah, if whole mount that tracks with this being kind of like a new type of protocol, I'm not surprised if some labs might evolve towards that too, because it's nicer to see the whole prostate in one whole mount.
Actually, we're talking about whole mount. The whole mount is what we typically take, like the whole face of the prostate gland before I've cut it, and process it as a whole. That whole ring gets processed as a big slice, and then processed again as a big piece. There's typically a bigger cassette that it can go into, like a mega-cassette. As it goes through processing, you can either process it on a regular tissue processor if the slices are thin enough, as it would be for a regular section. And then when it comes to embedding, at least in our experience here, you can actually create larger wax blocks using different tools so that you can then take it to a specialized microtome called a sledge microtome. Similar to a regular microtome, you draw the block of wax with the tissue across the blade, and you create one big paraffin embedded section that gets mounted onto a larger glass slide, and then it goes to the regular process. The nice part about this is that you can see the whole cross section of the prostate on one slide without having to piece together each quadrant. This is the Mega-cassette. It's huge by comparison to our regular standard cassette. Okay.
Yeah, I agreed.
You can put the whole cross-section of the prostate gland through in toto like that and process it as such, and it'll come out. You can create this paraffin block with a couple of different tools in the histo lab, and then take that wax block to this microtome to create this whole mount onto a glass slide. You can see the whole cross-section of the prostate gland on one slide without having to piece together 4 individual sections.
So I just want to add to that comment too, that the IHC, that's a very valid comment. So not only do you have to make allowances for the tissue processing and the cutting and everything, but also on the analytical side of things, hopefully your microscope has a stage. If you use a stage that can accommodate these giant slides, you now have 4 times the surface area that you need to cover. So a lot of these approaches actually just take a small amount or a region of interest that you can either cut out or draw one of those hydrophobic pens around and limit your immuno to that area of interest. So I've seen those things. They do make for amazing H&E pictures as a whole mount. I'm a big fan of it, especially for prostate. The other common reason that we have these mega cassettes is that in past, we used to do this for femoral heads.
We'll occasionally use this for fetal brain sections as well, and they're incredible slices.
Yes, okay. Incredible slices.
So yeah, this is the approach for doing prostates, and I won't belabor this whole exercise and show you how to put through each of these quadrants, but I think you understand the approach. This is our approach. And again, some of your individual sites might opt to do a whole mount as we've been discussing, or perhaps do each individual ring and then move from ring from base to or from apex to base.
So an anatomy of the prostate as it sits midline in situ in the body with its associated vas, as well as the seminal vesicles. I always like to point this out because this always used to confuse me. It still does. The terminology of the base and the apex, just because it's backwards in my head. I always think of it more as a bladder neck and a distal prostatic urethra, just to make it just kind of makes sense to me. And then this is the different zones. So it was a lot harder to imagine. So hopefully this cartoon will help solidify the different zones and areas in the prostate and their associated pathology. So in addition to anatomy, the central zone, which is more towards the posterior aspect, you've got the transitional zone over here, which is the area between the central and the peripheral zone areas, which in the green here kind of encompasses most of that peripheral. And this is where most cancers or carcinomas are located. That's why the clinical screening exam, which is the digital rectal exam, makes sense because posteriorly abutting this is the rectum, right? And so that's where most cancers, if they present, you can clinically palpate in this peripheral zone area for any nodularity. So just going over the specimen that we did today, a nice radical prostatectomy and our inking strategy, highlighting the base, which is that flattened area or bladder neck area and roughened area, compared to the more tapered, smoother look of the apex or distal prostatic urethra. Just again, showing the transverse cuts and just orienting everyone to kind of this weird shape of the prostate where you have to angle your cuts accordingly. And comparing the radial and perpendicular, the older method used to be this radial way of cutting the base and the apex. The more current recommended way is to do the perpendicular cuts as outlined on the right side of your screen. Again, just a sample showing those cuts through the prostate. The importance of orienting and keeping track of orientation is key, as you saw here. And then again, just the orientation of a typical work through for a radical prostatectomy case. So just a few notes on extra-prostatic extension, which is one of the things that on grossing should be noted because this affects stage, and we'll get to the stage later. Basically, is the presence of tumor beyond the confines of the prostate glands. Most importantly, this is an adverse prognosticator. That's why it upstages the tumor. This can be done both grossly and microscopically. There are certain criteria microscopically of when you can call something EPE. It's very uncommon in the lower grade prostate cancers. Similarly, seminal vesicle invasion is a bad prognostic factor and also affects the T staging. This is, as the name implies, a direct invasion of the seminal vesicles. Again, it can be appreciated both in gross as well as microscopically. Again, the margins are very important in this case, both the apex and the bladder, and with the perpendicular sectioning technique being the more preferred or recommended way. A few words about prostatic acinar adenocarcinoma. It's the most common form of cancer in men, and it increases quite significantly with age. A radical prostatectomy, weigh the specimen, orient, very important, familiarize yourself with the anatomy according to your institutional protocols. This is just a way to make sure that you're keeping track of your sections, submit quadrants, with the margins paying close attention to the base and the apex. The vas is also a margin, so remember that, as well as the capsule of the prostate. The tumor extent, because it has tumor staging implications, EPE, seminal vesicle involvement, and then finally describe the parenchyma and any incidental findings. And what's the most common incidental finding? Stones. So don't be surprised. The plea there is to remove those stones and be kind to your histotechs because they'll wreak havoc on the blade. And then just a few words on Gleason grading as per the ISUP. Always a nice reminder about the architectural distortion that happens during the evolution of prostate cancers. Some histology showing the nuclear features of a prostatic cancer, as well as the architectural features showing you these smaller glands in between all the normal prostate glands. And they typically have these very prominent nucleoli in the cells. These smaller glands that you see are indicative of prostate cancer. In the background, just to compare, are what normal prostatic glands look like. See here as well. And won't be complete without any Gleason scoring and grade grouping. So just keep this in mind in terms of both the Gleason score, the individual scores, and then now the grade grouping categories and their respective Gleason scores that fall under those grade groups. And finally, the PT staging for prostate adenocarcinoma. In all likelihood, for this case, if there is cancer, that is going to be PT2 or organ confined. It used to be that you would differentiate between left, right, or bilateral, but that's no longer important. It's just organ confined. And this is where we get into the extra-prostatic extension or seminal vesicle invasion, which differentiates 3A and 3B. And then finally, the PT4 is if there's invasion to the adjacent structures.